Um, for the last day and a half, we have heard a lot about treatment protocols and what we ought to do. People have different goals of treatments, and most of the goals that people have are symptomatic goals. I want to get rid of my libido, I want to have increase in erections, or I have more energy and more. Well, I just want to feel good, and they don't know what feel good is. And if we just look at hormones at a face value, I think more than likely you're going to miss 99% of all patients and in helping them in getting them feel better. As a pharmacist, I make money by selling medications, but at the same time, I realize that in order for me to continue doing that, the patient's health to feel better, and for patients to feel better, they have to take less of my medication. So it's like a catch-22, but that's what I'm trying to tell you guys is when you go through this drug therapy, you'll find out what doses really works and what doses are going to be out there that's going to be most helpful for our patients. Contraindications, I think we heard a few of those. Breast cancer, yes, for men. Prostate cancers. Anybody has high PSA, I mean, it's not an absolute contraindicated, but most of the physicians will agree that, hey, it requires further evaluation. Hematocrit, I just heard it was 48 instead of 50 now. So I can change my slides for next time. Thank you. Hyperviscosity, I mean, it has to do with fluid dynamics. And when I heard about viscosity of your blood and why people want to donate blood, especially if they're on TRT treatments, has nothing to do with thickness and what it can happen, but how the whole fluid dynamic works is what I heard. So anyway, the viscosity of the blood can definitely make a big difference. Of course, sleep apnea, heart disease, heart failure, I'm sorry. Anyways, disclaimer. If you have patients coming to you and they want to look better, they want to use it for athletic performance, they want to use it for physical appearance, or prevent aging. There's nothing wrong with prevent aging, but that's the wrong therapy to start off with TRT. And that we want to make sure we address those issues right away. Most of the time, the patients, they're asking for treatments for better performance. They're hiding behind something bigger. And that's where you guys come into play to figure out, hey, where are you stressed out? Where are you depressed? Where are you anxious about things, Look deeper into things and don't jump on TRT as the first line of treatments for these people. How do you give testosterone? Of course, standard dose, check levels, therapeutic range, check the older men's. Now, Dr. Holthouse said very eloquently that, hey, we have a range of between 280 or 300 to 1,000. It's humongous, It's like when you go out to the ocean, can I throw a fishing net that is big as an ocean? I say, you're going to catch everything in there, right? So that means everybody's normal. Unfortunately, everybody's normal. But we're going to find out what normal is to other people and what range do you want to go for it. And the choices you have for those medications to get in the normal range are very few. You have those IM injections, which are very commonly prescribed. You have the patches, which is not commonly prescribed because it has issues with the adhesive getting rashes all the time. I believe 16% of all population will get rash from those patches, so it's not a best choice. Transdermal, transmucosal gels and creams, both compounded and commercial ones. Oral agents, I believe most of the oral agents are having major issues with metabolites and are not heavily prescribed at all. Pellets, there is an approved pellets by FDA, so that has been used. Buccal testosterone, in 20 years, I do not think I have filled a single prescription for buccal testosterone, but it's out there. Of course, the injections, you have three choices. Short-actings, which is the propionate. If anybody has given any testosterone propionate before into the patients, it hurts like crazy. It's very painful. Short-acting, most of the people that use testosterone propionates are the athletes. They want to get the testosterone immediately, and say they want to use this product. Intermediate actings are the cypionate and anthate, between 8 to 12 days half-life. Again, those are intermediate actings. And of course, the long acting is the testosterone under canoate. I believe the testosterone under canoate right now is in the phase 3 clinical trial, so it should be getting pretty soon available to it. And that's once a month shot, so to speak. I'm not sure how popular that's going to be because most of my physicians prescribe this either daily or twice a week shots of testosterone IM. So I don't see weekly shots at all. I'm not sure if I'm going to ever see a once a month shot. So anyway, that's what's out there. And this is, to honest to God truth, most of the guys that take testosterone therapy at home, they do in the thighs, versus at the office, you do in the cheeks. So it's a major difference because it's a lot less painful if you do in the gluteus versus in the thighs is much more painful. When patients do the medication therapy self-administered at home, they're going to have a lot of side effects, a lot of pain. We do get a call from the patients that it's lumpy, it's painful, and a lot of times we'll ask them, hey, why don't you go back to the doctor's office and get a shot from there from now onwards, because it looks like the techniques are not correct. So we educate patients on the techniques, but that's what's happening over there. With the testosterone levels, again, you have to worry about peaks and valleys. So if you give shots once every month or once every 2 weeks, you're going to have high levels and low levels. So I like the idea what Dr. Holthaus said earlier, that he does it twice a week. But that's what we see normally, is twice a week. And we do see a daily shots as well of a very low amount, like 0.08 to 0.1 ml of test SIP on a daily basis as well. So those are already two things that works really well. It's the one that I like about the TRT with the injection is very inexpensive compared to everything else you do. So for patients' compliance, in terms of people have issues with finances, which is 98%, I believe. They have issues with finances. They will prefer this treatment the most. Starting dose 75 to 100 milligrams IM weekly, and you can divide them into multiple dosages. Painful injection site is very common, and of course you do have to monitor the hematocrit for these patients. Patches, again, I don't remember selling a whole lot of patches. And the main reason is because of the rash the patients get. So the good thing about testosterone patches is that it gives a continuous dose of a very low amount of testosterone on a daily basis. So in this patches, can read, but I believe it's about 5 milligrams per day is what you get. It's a very small amount. And that will tell you what I'm going to talk about next is how much do you really need testosterone per day? We have heard 50 to 100 milligrams, creams, gels, twice a day sometimes. I've seen prescriptions all over the maps. And I've seen prescriptions only maybe 5 to 10 milligrams per day. And the answer is somewhere in between or something like that. So we're going to find out about those as to what the right dosages are. Pellet therapies, again, pellet therapy, since it's got approved FDA approval, FDA approved 75 milligram pellets. Compounded pellets are available anywhere from, for guys, maybe 50 milligrams to all the way up to 200 milligrams per pellet. And yeah, the dosage is pretty high. People will put in anywhere from 4 to 6 pellets of this 200 milligrams each every 4 to 6 months. The pellets these are compressed pellets. And the biggest concern that as a compounding pharmacy would have is consistently having the same compression every single time we make a pellet. And that's always a concern. Most of the pellets are done today by machines. The human factor is gone. If any compounding pharmacy is still doing the pellets the old-fashioned way, either they are under the radar or they haven't been caught yet. Pretty soon they'll be gone. Most of the pellet manufacturers today are doing with machines, so there's some sort of consistency that's available today for you guys. So that's a good sign. There are, of course, some side effects, which is the surgical procedures. You have insertion issues. You have scarring issues sometimes, protrusions, or the pads coming out. And again, there's some minor issues like those as well. With the buccal tablets, it causes gum irritation. It's again, I haven't prescribed this a whole lot. I don't see any advantage of using this therapy a whole lot, other than the fact that, hey, if you can give a low dose testosterone coming through your mouth where you don't have to worry about it, I think it might be a better thing. But again, I don't see a whole lot of these things coming up. The transdermal gels is probably the most common one. They have the deodorant sticks now. They have this gel. I mean, they have all kinds of things for guys to do this part. The one thing that I'll tell you is common is any testosterone therapy commercially has a big black box warning on there. And the warning says that this medication can be transferred to your partners. So, and unfortunately, all the commercially available products are about 10 milligrams per gram, approximately. Some are 12.5 to 10 milligrams per gram. And you have to apply anywhere from 5 to 10 grams a day, sometimes twice a day, to get the dosage that you're looking for. And of course, if you apply 10 grams, imagine in a hotel room you start pumping those lotion, 10 pumps. How much surface area do you need to have to apply all those 10 pumps of lotion? The whole body, pretty much, right? So that's the issue that you have with the testosterone, is that it requires a large surface area to apply this cream or the gel to get absorbed. And hence, if you touch anybody, the medication will be transferred to to your person. And sometimes most of the time it's your friends and family, your kids, your wives. It's not pretty. But anyway, so that's what the choices are at this time, and that's one of the reasons why FDA has put this black box warning, because it is a big issue, and they have found lots of complaints coming to the MedWatch program through that process. The one that, of course, the compounding pharmacy loves, because it's like the hormones in women. Do anybody prescribe estradiol 2 milligrams, estrase 2 milligrams? No, we don't, because guess what? You get a job done with half a milligram or maybe less than half a milligram. Why would you give 2 milligrams of estradiol when you can get the job done with a much, much less amount? Same thing with testosterone. Do you need to have 50 to 100 milligrams every single day or twice a day coming to you? No, you can probably get away with a lot less dosages if you know the application site is, and better yet, they're seeing a physician who understands that testosterone or estrogens for female is not the only therapy. It requires a whole body approach, functional medicine approach, to take care of all the other issues before you get to this therapy. And by the time you get to this hormone therapy, what your needs are very, very small. And so I get prescriptions on both ends. I get high-dose prescriptions, I get low-dose prescriptions. And you want to guess which one I get refilled the most? Low dose. Why? Because those doctors, they are prescribing low dose, understands that it's not the hormones that are doing the thing, it's the whole body approach, the insulin, the thyroids, the cortisol, the stress factors, and exercise, and everything. Once everything gets into control, and then you give a little bit of hormones, it's like, oh my goodness. Right? So that's what we see the most of it. And it has nothing to do with what's effective for the patients. It's all about the physicians being in tune with the patients the most. Okay? Unlike females, for men, there is no perfect system for giving testosterone therapy. Either whatever you do, you either going to raise too much estradiol levels or you're going to raise too much DHT levels. You can try and minimize those problems by giving them low dosages, increasing the frequency of treatments, things like that. For example, the estradiol issues with the injections. So instead of giving once every 2 weeks injections, you can give twice a week injections. It's a little bit more painful, but at least you will have less estradiol levels. But if you give daily shots, sub-Q daily testosterone shots, Sub-Q testosterone can also increase estradiol levels very high. And so most of my doctors that I work with, they prescribe daily low-dose testosterone shots, sub-Q. Every one of those patients are on aromatase inhibitors at the same time because the conversion is pretty high. So if you give them topical testosterones, doesn't matter where they're applied, you have the potential of increasing DHT, hence baldness, and most of the guys. I'm the only bald person in my family, by the way. My dad's 83. He has a full set of hair. He takes testosterone every single day for the last 15 years, and his full set of hair, and then looks at me and said, "What happened to you?" I said, "You gave me bad genes." I can't blame myself, you know. So it does happen, so we have to watch out for those as well. To maintain estradiol levels, you have to control the aromatase enzyme activity. And it's the conversion from testosterone to estrogens. The aromatase enzyme activity can be converted in two ways. One, there's a speed of reaction that you can slow down. And the second thing is you can block it, right? If something is moving really, really, really fast, can you stop it? Think about it, right? If something is moving really fast, can you stop it? Chances are, yes, you probably maybe will stop it, but you're going to get hurt in the interim of stopping this person because it's moving really, really fast. So then the issue is that how can we reduce the enzyme activity, the process, the reaction time lower, and then we can stop it. So think about it. When you're highly stressed, you have low zinc. What happens to the enzyme's activity? Is really fast. It speeds up the process. So stress causes the reaction from testosterone to estrogens at a very high speed. To slow the reaction process down, you can take some zinc. And then if you want to stop it, you can take Aromatase. I had chrysin in my arsenal before. I did chrysin before, but just want to let you know, FDA just released a document about less than a couple of weeks ago. The chrysin will no longer be available to prescribe. So unfortunately, chrysin is gone. So it's in my slides, I still have chrysin, but it's gone. And then, of course, the biggest issue with the testosterone is with the conversion from testosterone to estrogen is gynecomastia. So, and we see this in the guys all the time. Yeah, that's it. Hey, my eyes are up here, you know. So, sorry. I had some jokes last night, but I had to take all my slides off because it was too late last night. So I said I'll put some more today for you guys. All right. So for the aromatase activities, of course, zinc deficiency is a big thing. So a lot of my guys are on zinc deficiency, zinc capsules. When you take zinc, be careful not to give too much of zinc because it can deplete copper. So the barometer for me is anybody taking more than 30 milligrams of zinc per day is automatically given copper. Unless you have copper piping in your house and you have plenty of copper from your shower every day, other than that, you're taking a little bit of copper with it. So zinc, 30 milligrams or less, or 30 milligrams or more with copper. Of course, you can find in some oysters, red meat, and nuts. I can only eat nuts. I don't eat oysters or red meat, so I do love nuts. So I do take my nuts every day. Alcohol consumption can also reduce both zinc and magnesium. It's funny about alcohol because I just tell you simple things. I'm doing a study on alcoholism right now because I'm trying to figure out how I can get people sober up really, really fast with the glutathione project. But finding out average consumption of alcohol per day in the United States. Per day. 2 to 3 drinks, right? So I said, okay, good. It's only about 2 drinks per day. It's not so bad, right? 1 to 2 is okay. Then I found out is that average consumption per setting. Per setting. So there's 2 different things. It's per day is one, and per setting is another one. Because per setting is about 8. So what it comes up is that, hey, that means if we average it out, because people drink twice a day in a week, which is 16 drinks, per day comes out to 2 per day, but per setting is much, much higher. So that's the part that was concerning to me. Again, I've not fully understand the whole research parameters of how they're doing this thing yet, but I started finding out. I said, hey, if it's all binge drinking pretty much, when they're drinking so much, what's happening to the zinc levels those 2 days is pretty high. So that's the time that I'm worried about right now is how much stress is it putting on our body. The enzymes, the meds that you have available are aromatase inhibitors, are anastrozole, which is the most commonly prescribed, probably the cheapest one, letrozole, which is Femara, aromacin, newest one. Again, there's all those choices available to you. Probably the anastrozole is the most prescribed because it's not just because it's cheapest, but because it's been studied the most. It's been available in the market the longest. Chrysin is a natural aromatase blocker, but unfortunately no longer available. Most of the doctors, I learned this from a doctor out of Belgium in 1999, that he used to prescribe every man that got testosterone therapy with liberal progesterones. And so for the last 20 years, all of the testosterone that we make for our doctors, I put a little bit of progesterone inside, 1%, okay? And that's the therapy. And this is why he does that part, because progesterone does stimulate the lytic cells to secrete testosterone. More than that, what I'm using the progesterone for is that it can literally block the 5-alpha enzyme. You know, it can reduce the PSA. So I'm trying to figure out, I said, hey, if I give progesterone topically, if I give testosterone topically with some progesterones, will I be able to block the DHT conversion, right? So that's the theory behind this thing, and that's what we have been prescribing for the last 20 years, and it seems to be working on most of the patients. DHT blockers, you have choices of finasterides, dutasteride, saw palmetto, stinging nettles, the pigeons. But I'll tell you one thing, I don't see anybody using these products on a mass. Very, very rare. Be very careful when you use DHT blockers. At one point, you can have patients going bald. On the second part, if you do get a prostate cancer, this cancer is going to be super aggressive. So we are very, very careful. Most of the doctors do not prescribe DHT blockers unless the patient is absolutely adamant about having to worry about hair loss issues. And for those, sometimes we do have finasteride topical solution with some minoxidil. It's okay. I'll prefer not to use anything, but you know what? Some patients, they have to use something, so we do that part. Typical prescriptions for testosterone. This is what we see all the time. So testosterone's 9 milligrams of 9-to-1 ratio of about between 5 and 50 milligrams of testosterone to be applied to the anal mucosal membrane or the perineum area. Again, we talked about it yesterday about the females. We apply on the anal labia. For the guys, we apply on the perineum area, on the anal mucosal area. Now, that's one theory. The second theory is we get 5 and 10% testosterone topically to be applied BID, and those are applied inner thighs, lower abdomen, inner arms, and all the other fatty areas. Again, that's an old school process, and I have doctors prescribing both the times. But I'll tell you, if I did the presentation about 10 years ago, the first line never existed. Nobody prescribed low-dose testosterone. Everybody that we saw was prescribing high-dose testosterone between 5 and 10%. BID is what we see all the time. Over the last 10 years, I see a lot of prescriptions just coming down to between 10 and 50 milligrams of testosterone per day with liberal progesterone, and the patient seems to be much, much better tolerated, less side effects. And when you do that part, they are not getting super physiologic dosages, and the doctor is much more in tune with all the other therapies that they are trying to do. So, anyways, so that's where we're seeing a lot of it. Scratch of the chrysin plus zinc, that's all gone now. Pregnenolone DHEA, again, guys are already mentally challenged to begin with, you know. there's a birth defect that we got that we can't think with the two hemispheres of the brain. So anything to help boost the memory a little bit, we'll take it, right? We'll take every chomp of it. So preg DHEA, predominantly for guys, has always been oral pregnenolone DHEA. We don't prescribe topical at all because topically we already get testosterone as an androgen to help with minor aches and pains all over the body. So we don't need to do that part. On the female side, we always give DHEA topical for aches and pains, but for the guys, it's always been pregnenolone DHEA orally. They can take a lot more DHEA than females can take because the skin is a little bit thicker. They don't get so much acne right away, so the guys can take a little bit more than women can. DHT blockers saw palmetto with nettle roots and pygeum is probably the most commonly prescribed out of all the other available choices, but even those are very rare. Anastrozole, I do see a lot of anastrozole prescriptions, and I feel like that if you're giving anastrozole prescriptions, is it a possibility that we can reduce the testosterone levels doses down? If it's a possibility, let's work on that instead of giving them more testosterone and then blocking the conversion from testosterone to estrogens. You know, I ask the doctors all the time because I consult with a lot of physicians all the time about when we do drug therapies. So I ask the doctor, your average male patient that comes to your office to get your testosterone therapy, what's his lifestyle? Gets up in the morning, you know, rushes out of the home to get to work. He's working all day, comes in the evening, eats dinner, sits on sofas, watch TVs, falls asleep on the sofa, wife picks him up, puts him in the bedroom, and goes to sleep. That's one. Number two, a guy wakes up, he's a little bit more energetic. He wakes up in the morning, does a little bit of exercise, same routine the whole day, comes in the evening, he's lethargic and tired, the cortisol level is really low, falls asleep on the sofa, wife picks him up, puts him in bed, goes to sleep, right? So average man is not the guy that works out in the morning for 2 hours, goes to the massage all day long, works on his body and relaxes every day, and then eats the right foods and all the meats and proteins and everything, perfect meal, and ready at nighttime, goes to sleep 8 hours, wakes up in the morning, and this whole routine again. So if the male patient is not in tune to use all this testosterone that you're going to give them, what's going to happen to this testosterone? So that's the way I think, I work with the physicians as we're thinking about it, is if you give too much testosterone to these male patients and they cannot use it up, what's going to happen? Centripetal fat tissue starts developing. So I have a lot of guys that the more testosterone I give them, the fatter they get. And I tell doctors, we got to think differently. Cut him off. So if I cut him off, the sex drive will go down. They're not going to feel good, and you know it's a cascade of problems. And they're afraid to take the testosterone away from these guys. So we do now is what? We don't give them enough from the beginning. We just give them low dosages, so that way they just ease up into the low dosages, and then they're not thinking about getting high doses from the beginning. And that seems to be working a lot for our patients right now. Secondary hypogonadal patients, sometimes we use HCG. It's the LH. Clomiphene is the FSH. So we use LH and FSH to boost the testosterone levels. But keep in mind, when you do that part, you're also going to increase the estradiol levels. So you just have to be careful and when you give those types of therapies as well, in lieu of giving testosterone. Of course, I'm a pharmacist, so I like combination pills and things like that. So I make this combo pill. It's like progesterone, 25 milligrams, pregnenolone, 10 milligrams, DHEA 5, 7 keto. By the way, we can't do 7 ketos either anymore. Pretty soon, I believe that's going to be gone too. Anastrozole 0.05, methyl B12 0.5 milligrams, and B6 2 milligrams. The whole thing can be in one capsule and give to your patients, and this is a secondary way of increasing testosterone without actually giving testosterone. So these are good for actually guys in the early 30s that need some testosterone boosting. Now, this one I see a lot of it. I see guys going to the gym, you know, They shoot up some medications from off-market products. There's no label on the bottle. I said, what did you get? I said, I don't know. The guy at the gym gave it to me. I said, what's on the bottle? He peeled the label off because he didn't want to know where he got it from. I said, geez, how do I know what you're getting? So they shoot up some anabolic steroids in the gym, and then they come to the physician and say, hey, doc, I'm getting married. I want to have kids. And what do you do next? And doc says, what am I going to do, right? You made the bed. So anyway, so this is a one-time get out of jail free card is what I tell the doctors. One time, I'll give it to you. I give HCG 2,500 units every other day for 16 days. Clomid 50 milligrams daily for 30 days. With this high dosages, what's going to be a problem? Gynecomastia. Hence, tamoxifen 20 milligrams daily for 45 days. Okay? At this end of the therapy, if you revive your testes to produce your testosterone, you let them go back in the wild again. And you tell them, please don't come back to me again. Find another physician who's going to give the same therapy again because it may not work again. So this is what we do for patients that they have abused some hormones in the past and now they want to revive the gonads again to produce their own testosterone. Side effects, of course, we always have side effects with the testosterone therapy. The biggest one, of course, is the gynecomastia. If it's too much of testosterone, you have chromosomal fertility. I believe testosterone therapy is considered as a male birth control. And you have fluid retention because of too much of estrogens. And, of course, increased body hair. Oh, Mr. Rosenberg, your testosterone level seems pretty good, but it's a little high. So this is hirsutism. Conclusion, testosterone therapy is not the answer for every single thing. Please look back into your notes and see if insulin can help them, thyroids can help them, stress can help them. Androgen therapy is supposed to be the last line of therapy. And before you give anybody testosterone therapy, glove up and check it out before you prescribe testosterone. Thank you very much. Appreciate it. Thanks.